We will discuss about three topics today, that is the tumor lysis syndrome, the superior vena cava syndrome and the leukostasis. So first is tumor lysis syndrome. Tumor lysis syndrome is one of the most common oncologic emergencies. It is caused by the inability of the body's homeostatic mechanisms to handle the massive release of intracellular contents . Tumor lysis syndrome is one of the most common oncologic emergencies. It is caused by the inability of the body's homeostatic mechanisms to handle the massive release of intracellular content, that is potassium, phosphate and nucleic acids, from disintegrating tumor cells into the bloodstream. Catabolism of the nucleic acids to uric acid leads to urate deposition in the renal tubules, resulting in acute kidney injury and its associated complications. These metabolic disturbances can lead to clinical toxic effects including cardiac arrhythmia, seizures, multi-organ dysfunction and death. The etiopathogenesis. When a cytotoxic therapy is initiated for a chemotherapy sensitive malignancy, particularly one with a large disease burden or rapid proliferation, there is rapid cell lysis with release of intracellular contents, that is nucleic acids, potassium and phosphate into the bloodstream. The nucleic acids are catabolized into hypoxanthine, xanthine and then to uric acid by the enzyme xanthine oxidase. Uric acid has a pK of 5.4 to 5.7 and is poorly soluble in water. Under physiologic conditions, approximately 500 mg of uric acid is excreted by the kidneys daily. With rapid tumor lysis, uric acid precipitates into crystals in the acidic environment of the distal renal tubules and the collecting system of the kidney. Deposition of the urate crystals in the renal tubules leads to acute uric acid nephropathy with AKI. This is the flowchart showing the process of tumor lysis, that is a breakdown of the cells with release of nucleic acid due to excessive purine catabolism, release of hypoxanthine, which is converted into xanthine by xanthine oxidase, and further xanthine is converted to uric acid by xanthine oxidase, and there is an enzyme which is absent in humans, that is urate oxidase, which causes further conversion of the uric acid into allantoin. The rapid tumor lysis also leads to hyperphosphatemia, since phosphorus concentration in malignant cells is significantly higher than in normal cells. Initially, the kidneys respond by increased phosphate excretion and reduced tubular reabsorption of phosphorus, but eventually the increased renal excretion is overwhelmed and serum phosphorus levels rise. This hyperphosphatemia leads to calcium phosphate precipitation, which is also known as nephrocalcinosis, with secondary hypocalcemia. Renal replacement therapy is often needed when calcium phosphate product is more than 70 mg per deciliter. Precipitation of the calcium phosphate in the heart may lead to cardiac arrhythmias. Massive release of intracellular potassium may also exceed renal clearance capacity and lead to hyperkalemia, which is further accentuated by renal failure. This rapid rise in serum potassium leads to cardiac arrhythmias and may be life-threatening. The clinical features. Clinical features associated with TLS stem from the associated metabolic abnormalities, that is hyperkalemia, hyperphosphatemia and hypocalcemia. These may include nausea, vomiting, anorexia, lethargy, hematuria, heart failure, edema, cardiac dysrhythmia, seizures, muscle cramps, tetany, syncope and possible sudden death. Though uncommon, acute uric acid or calcium phosphate deposition with renal pelvic or ureteral stone formation can lead to flank pain. The urinalysis shows rectangular or rhomboid uric crystals. The definition of TLS. Cairo and Bishop proposed a definition for TLS in 2004 along with a grading for clinical severity. These are the most widely used criteria to diagnose and classify TLS. This is of two types, one is laboratory TLS, another is clinical TLS. Laboratory TLS is defined as a 25% change from the baseline or levels above or below normal for serum values of at least two parameters out of serum uric acid, potassium, phosphorus or calcium within 3 days prior and up to 7 days after initiating the therapy. This is the laboratory TLS. definition given by the Cairo-Bishop score, uric acid more than equal to 8 mg per dl or 25% increase from baseline, potassium more than equal to 6 millimole per liter or 25% increase from baseline, and phosphorus more than equal to 2.4 millimole per liter in children and 1.45 millimole per liter in adults or 25% increase in from the baseline, and calcium is less than equal to 7 mg per dl or 25% decrease from the baseline. Tumor lysis syndrome is defined by the presence of 2 or more of these criteria. Now the clinical TLS. The clinical TLS is defined by the presence of laboratory TLS plus at least one clinical implication, that is increased serum creatinine, cardiac arrhythmia, sudden death or seizure. The grade 1 is grade 0. The creatinine is less than equal to 1.5 of the upper normal limit. There is no cardiac arrhythmia, there is no seizure. In grade 1, the creatinine is 1.5 of the upper level of the normal. There is cardiac arrhythmia, but intervention is not needed. In grade 2, it is 1.5 to 3, and there is non-urgent medical intervention indicated for cardiac arrhythmia, and there is one brief generalized seizure or seizures which is well controlled by anticonvulsants or infrequent focal motor seizures not interfering with ADL. In grade 3, there is the creatinine is more than 3 to 6. It is the cardiac arrhythmia is symptomatic and incompletely controlled medically or controlled with a device, that is defibrillator. The seizure is where the consciousness is altered, poorly controlled seizure disorder with breakthrough generalized seizures despite adequate medical intervention. In grade 4, the creatinine is more than 6. The cardiac arrhythmia is life threatening, which is associated with congestive heart failure, hypotension, syncope and shock, and seizure of any kind which are prolonged, repetitive or difficult to control, example status epilepticus or intractable epilepsy, and in grade 5 there is death. The risk factors and predictors of TLS. Firstly, we will see the patient related risk factors. Number 1 is the pre-treatment hyperuricemia or hyperphosphatemia, pre-existing renal dysfunction, oliguria and or acidic urine, and dehydration or volume depletion. Now the tumor related risk factors. It is inherent chemotherapy sensitivity of the tumor, high proliferation rate, LDH is a marker for tumor proliferation, large tumor volume as evidenced by large tumor size more than 10 cm, WBC count more than 50,000, organ infiltration, extensive metastasis or bone marrow involvement. Number 4, renal infiltration or outflow tract obstruction. Patients with aggressive lymphomas and acute leukemias with high cell counts are also at risk of spontaneous TLS even without the initiation of therapy. These patients should be recommended aggressive hydration and considered for TLS prophylactic agents even while full diagnostic workup is underway. Now the treatment related risk factors. The intensity of the anti-cancer therapy, that is multi-drug regimens, specifically targeted agents e.g. venetoclax and optinumab for chronic lymphocytic leukemia, exposure to nephrotoxin, example concomitant vancomycin or aminoglycosides or contrast agents, suboptimal fluid administration during therapy, and exogenous potassium or phosphorus. The prevention of TLS. The management of established TLS is often difficult and resource intensive. Hence, all efforts must be made to identify patients at high risk of TLS early and institute preventive measures to prevent the clinical TLS. There are two main strategies to prevent TLS, that is aggressive intravenous hydration and hypouricemic agents, allopurinol or recombinant uratoxidase. The specific type of prophylaxis depends on the risk category as ascertained using factors enumerated later. Low risk of TLS, intermediate risk of TLS, high risk. Low risk has incidence of more than 5%, most solid tumors. Intermediate risk is highly chemotherapy sensitive tumors, example neuroblastoma, germ cell tumor, small cell lung cancer, other cancers with bulky and advanced disease. Low risk TLS is there in multiple myeloma, intermediate risk is in plasma cell leukemia. Low risk is also there in indolent non-Hodgkin lymphoma, Hodgkin lymphoma. CLL and WBC less than 15 to 10 to the power 9 per liter treated only with alkylating agents have low risk of TLS. CLL which is treated with fludarabine, rituximab or lenalidomide, or venetoclax and lymph node greater than equal to 5 cm, or absolute lymphocyte count more than 25 into 10 to the power 9, and or those with WBC more than equal to 50 into 10 to the power 9 have intermediate risk of TLS. CLL which is treated with venetoclax and lymph node more than equal to 10 cm or lymph node more than equal to 5 cm and absolute lymphocyte count more than equal to 25 into 10 to the power 9 liter and elevated baseline uric acid has high risk of TLS. AML and WBC less than equal to 25, AML with WBC less than equal to 25 into 10 to the power 9 per liter and LDH less than 2 of the upper limit of the normal have low risk of TLS. The AML with WBC count 25 to 100 or AML with WBC count more than equal to 25 into 10 to the power 9 liter and LDH more than equal to 2 has intermediate risk, and AML with WBC count more than 100 into 10 to the power 9 per liter has high risk of TLS. Adult intermediate grade NHL and LDH within normal limits have low risk of TLS. Adult T cell leukemia, lymphoma, diffuse large B cell, transformed and mantle cell lymphomas with LDH greater than upper limit of the normal, non-bulky have intermediate risk. Adult T cell leukemia, lymphoma, diffuse large B cell, transformed and mantle cell lymphomas with bulky disease and LDH more than two times of the upper level of the normal have high risk. The recommended prophylaxis adult ALCL has low risk of TLS. Childhood ALCL stage 3 and 4 have intermediate risk. Childhood intermediate grade NHL stage 3 or 4 and LDH less than 2 of the upper level of the normal have intermediate risk. Whereas stage 3 or 4 childhood diffuse large B cell lymphoma with LDH more than 2 have high risk. ALL with WBC count less than 100 into 10 to the power 9 and LDH less than 2 have intermediate risk. Burkitt's leukemia or other ALL with WBC count more than 100 into 10 to the power 9 and or LDH more than 2 have high risk. Burkitt's lymphoma and LDH less than 2 times have intermediate risk. More than 2 LDH and Burkitt lymphoma stage 3-4 have high risk. Lymphoblastic lymphoma stage 1 or 2 and LDH less than twice is intermediate risk, and lymphoblastic lymphoma stage 3-4 and LDH more than 2 have high risk. The prophylaxis which is required for each of these 3 stages. For low risk with TLS there is monitoring, hydration plus minus allopurinol. For intermediate risk it is monitoring, hydration and allopurinol, and in case of high risk it is monitoring, hydration and rasburicase. Less than 1 sir. Low risk of TLS 8 tumor gune 8 most incidence পাওয়া যায়. Low risk tumors with low risk of TLS এই টিউমার গুলোর ইনসিডেন্স সবচেয়ে বেশি. More than 5% of the TLS have low risk. More than 5% of the tumors have low risk for TLS. 1 to 5% of the tumors have intermediate risk and less than 1% have high risk. The treatment of established TLS. Patients who develop TLS despite prophylactic measures or spontaneously should undergo continuous cardiac monitoring and measurement of serum electrolytes, uric acid and creatinine every 4 to 6 hours. Management of these cases includes intensive hydration with or without loop diuretics, treatment of specific electrolytes abnormalities as per standard guidelines, and use of rasburicase if already not indicated. Hyperkalemia Hyperkalemia can cause cardiac dysrhythmias and sudden death. Glucose plus insulin or beta 2 agonists can be used for transcellular potassium shift as a temporary measure. Calcium gluconate can be administered to reduce the risk of cardiac dysrhythmia. Oral potassium lowering agents, e.g. sodium polystyrene sulfonate, should be used, and renal replacement may be needed in refractory cases. Hyperphosphatemia can be managed with aggressive hydration and phosphate binders, e.g. cebelamide hydrochloride or lanthanum carbonate. Hypocalcemia should be treated only if symptomatic, that is there is cardiac arrhythmia or tetany at the lowest dose needed to relieve the symptoms in order to avoid calcium phosphate precipitation. Renal replacement therapy may be needed in cases of electrolyte dysregulation that is refractory to medical management. This is a flowchart showing the management of the TLS. that is hyperuricemia, uric acid more than 8, hyperkalemia, hyperphosphatemia or hypocalcemia. If two of these criteria are not met, then there is no TLS. We assess the risk for TLS. If it is low risk, then we focus on adequate hydration. If it is intermediate risk, we assess for we give hydration, daily allopurinol prophylaxis, and consider rasburicase if hyperuricemia develops despite allopurinol. If there is high risk for TLS, then we give IV fluids, rasburicase, telemetry monitoring, monitor labs 6 to 8 hours, and they might not need ICU monitoring. If there is laboratory TLS plus acute kidney injury or symptomatic hypocalcemia or cardiac dysrhythmias, then it is clinical TLS. So we give IV fluids, rasburicase, telemetry monitoring, labs for Q4 hourly, needs ICU monitoring, and might need renal replacement therapy if does not respond. The key points: the tumor lysis syndrome is a rare but potentially life-threatening complication of highly proliferative or chemotherapy sensitive cancers, which are most commonly hematological malignancies. Early identification of risk factors such as type of malignancy, chemotherapy regimen and age, followed by prompt institution of appropriate TLS prophylaxis, can be life-saving. Vigorous hydration, fluid balance, electrolytes and hyperuricemia correction form the cornerstone of managing TLS. Now the superior vena cava syndrome. The superior vena cava syndrome is a condition which is caused either due to the intraluminal or extraluminal compression of the superior vena cava. This is the anatomy of the superior vena cava. The superior vena cava is a thin-walled compressible vessel which drains the blood from the head, limbs and the torso. It lacks strong architecture similar to the trachea or high internal pressure like aorta, hence it is vulnerable to compression and obstruction. Any mass in the anterior and medial mediastinum can easily compress the superior vena cava. In cases of superior vena cava syndrome, pressure in the superior vena cava up to 20 to 40 mmHg has been reported, in contrast to normal central venous pressure of 2 to 8 mmHg. This increase in venous pressure leads to development of collateral vessels if the obstruction occurs gradually. The azygos vein, which connects the superior vena cava with the inferior vena cava, it forms the collateral for pathways during obstruction. However, if obstruction is distal to the superior vena cava, the occlusion is above to the origin of the azygos vein and the blood is diverted through small collaterals. These are the causes of the superior vena cava syndrome. The malignant causes include carcinoma lung, lymphomas, metastasis, thymoma, sarcoma, other adenocarcinoma and mesothelioma. Benign causes include the portacath, dialysis catheter, fibrosing mediastinitis, pacemaker, radiation fibrosis, Behçet syndrome, retrosternal goiter, giant bulla, congenital vascular defect and granulomas. Diagnosis. Diagnosis of the SVC syndrome is primarily clinical and is supported by imaging to demonstrate the obstruction. The symptoms are usually exacerbated by maneuvers that increase the supracardiac venous pressure, like performing the Valsalva maneuver, leaning forward and lying supine. These are the symptoms according to the incidence. Most commonly the facial edema followed by dyspnea, then dilated neck, chest vein collaterals, distension of the neck veins, cough, hoarseness, edema of upper extremities, plethora, syncope, dizziness, confusion, stridor, and lastly mental obtundation. Imaging. Chest X-ray may reveal widening of the superior mediastinum in cases of mediastinal masses, about 75% of the cases. Ultrasonography can rule out the thrombosis of subclavian, axillary and brachiocephalic veins in patients presenting with upper limb edema. CECT will reveal the extent of tumor involvement of the surrounding structures, brain metastasis, while venography can detect the presence of any intravascular thrombus. MRI venography can be used in patients allergic to iodine contrast. Diagnostic bronchoscopy may be required to detect the endoluminal tumor growth. Tumor histology. Tissue diagnosis of the tumor is essential for the treatment. Sputum examination and pleural fluid cytology for cases of carcinoma lung, peripheral lymph node biopsy for suspected lymphoma can establish the histology of the tumor. At times, thoracoscopy and mediastinoscopy may be required. This is the grading of the superior vena cava syndrome. Grade 0 is asymptomatic, SVC on imaging without symptoms. Grade 1 is mild, edema of the head and the neck. Grade 2 is moderate, edema in the head and neck with functional impairment. Grade 3 is severe, that is mild or moderate cerebral edema or laryngeal edema or diminished cardiac reserve. Grade 4 is life threatening, significant cerebral edema, laryngeal edema, hemodynamic compromise and grade 5 fatal death. Management. The management of superior vena cava syndrome depends on the severity of the symptoms, probability of response to treatment, that is oncological etiology, and patient's performance status. Often a multidisciplinary approach involving the intensivist, medical oncologist, radiation oncologist and intervention radiologist is needed. Patients presenting with symptoms such as coma, cerebral edema, syncope, airway and hemodynamic compromise require immediate admission to the ICU for stabilization and control of symptoms while waiting for the results of other investigations to formulate the future treatment plan. Number 1 includes the general care. Patient should be nursed in 45-degree head up position to reduce the hydrostatic pressure in the veins of the upper torso. Venous access should be obtained in the lower limbs. Anticipated difficult airway. Difficult ventilation should be anticipated, especially if there is orthopnea, stridor or bronchial compression on imaging. Diuretics and corticosteroids can help reduce airway edema, but steroids may be avoided if lymphoma is the provisional diagnosis and biopsy is pending. Esophageal varices with occasional variceal bleeding may be present in chronic superior vena cava syndrome. Now, interventional radiology. Endovascular stenting provides immediate relief from severe symptoms and has proven to be effective even in cases of relapsed malignancies. Stenting may be avoided if rapid response to chemotherapy is expected or a tumor is potentially amenable to surgery preceded by chemotherapy. Example, thymoma. Stenting is feasible if the patient can lie supine under local anesthesia, headaches resolve fast, followed by facial and truncal edema. Short-term anticoagulation is often required after stent placement. Superior vena cava syndrome of benign etiology is managed with endovascular therapy. In superior vena cava syndrome due to thrombosis, stenting, catheter-directed thrombolysis or mechanical thrombectomy can be considered. An intravascular device like pacemaker wires or central venous catheters may be removed. This is the Kishi scoring system for decision to initiate the stent therapy, which has the neurological signs, that is awareness disorder or coma, visual disorder, mental disorder, malaise, thoracic or pharyngeal or laryngeal signs, that is orthopnea, laryngeal edema, stridor, dysphagia, coughing or pleurisy, facial signs, that is lip edema, nasal obstruction or epistaxis and facial edema, and vessel dilatation, neck, face or arms. A score of 4 or higher indicates a need for percutaneous stent replacement adopted from Straka al Springer plus 2016. Radiotherapy. Radiotherapy can be palliative or definitive. Palliative radiotherapy is recommended for radiosensitive tumors like non-small cell lung cancer, encroaching critical structures in the mediastinum to halt the progression of cardiac and respiratory symptoms. Definitive radiotherapy is administered with curative intent in cases of low-grade lymphoma, stage 2 or 3 non-small cell lung cancer or small cell lung cancer with limited disease. Radiotherapy can sometimes cause local edema with exacerbation of symptoms during treatment of superior vena cava syndrome due to radiation fibrosis later. Chemotherapy and immunotherapy. Lymphomas, germ cell tumors and small cell lung cancer. Life-threatening symptoms, we stabilize, secure the airway breathing circulation. Venogram, urgent stent. If thrombus is present, we consider catheter-directed thrombolysis. If there is no life-threatening symptoms or moderate to severe symptoms, tissue biopsy and staging evaluation. If it is life-threatening symptoms, it can be SBC syndrome at confluence of brachiocephalic vein. We do a double barrel approach or a Y approach. Double barrel approach is more common. If there is non-thrombotic causes of SBC syndrome, we do angioplasty followed by stent replacement. If it is SBC syndrome due to thrombosis, we confirm thrombosis, consider the catheter-directed thrombolysis plus minus stent. If catheter-directed thrombolysis is contraindicated, we consider mechanical thrombectomy. SBC syndrome of benign etiology, we consider endovascular therapy as first line, as it does not preclude from the future surgical bypass. Notable consideration: device-related SBC syndrome, e.g. pacemakers, central venous catheter, we consider lead removal and subsequent stent placement. SBC obstruction due to chemosensitive, radiosensitive tumor, we treat the underlying cause. If there is tumor such as thymoma, we consider surgical excision. Now, leukostasis. Hyperleukocytis is defined as the total leukocytic count more than 1 lakh per microliter of the blood. Leukostasis or symptomatic hyperleukocytosis is tissue hypoperfusion due to extremely elevated leukocyte count or blast cell count. Etiology: hyperleukocytis is associated with specific subtypes of leukemia. In AML, hyperleukocytosis is associated with monocytic differentiation types M4, M5, whereas in APML and ALL, an association with T1411 and T1922 is observed. In CLL, symptomatic hyperleukocytosis occurs only if WBC count is greater than 1 lakh. The pathophysiology: patients with hyperleukocytosis are at risk for development of tumor lysis syndrome, DIC and leukostasis. There can be a vascular obstruction and tissue hypoxia leading to myriad of systemic manifestations. There are two theories which are proposed for the pathophysiology of leukocytosis. Number one is the rheological theory, where the viscosity of the blood depends on deforming capacity of the cells and total volume of the cells in the blood. In cases of high leukocrit, increased blood viscosity is due to increase in volume of WBCs in the blood. As per this proposed theory, the myeloblasts are bigger and less deformable than lymphoblasts and lymphocytes. So, leukostasis is more commonly observed in AML than ALL and CLL, where it occurs at much higher counts of WBC. While the second theory focuses on the interaction of the endothelium with the blast cells. Endothelium, when activated by blast cells, secretes cytokines and adhesion molecules such as VCAM and selectins, which promote the adhesion of the blast to the endothelium. Generally, leukostasis occurs at a lower counts in myelomonocytic and monocytic AML, that is more than 15 to 10 to the power 9, compared to other AML and CML, where it is more than 100 into 10 to the power 9 per liter. Leukostasis is rare in ALL and are seen at very high counts, that is more than 400 into 10 to the power 9 per liter. Patients with leukostasis are at high risk for concomitant tumor lysis syndrome. The clinical features of hyperleukocytosis is as per the systems affected. If the CNS symptoms are stroke, altered mental state, headache, focal neurological deficit, confusion, coma, blurred vision, tinnitus. Cardiovascular system, there is congestive heart failure. Respiratory system, there is pulmonary infarct, pulmonary hemorrhage, pseudo hypoxemia, which is also known as leukocyte Lasserni, tachypnea, dyspnea and rales. Genitourinary, renal infarct, stones and priapism. GI system, bowel ischemia, splenic infarcts, Budd-Chiari syndrome. Hematological system, DIC, thrombosis, lab abnormalities which are low fibrinogen, increased FDP and D-dimer. Management is aimed at reducing the WBCs and supporting the circulation. In acute phase, patient should be admitted to the ICU for monitoring and stabilization. Aggressive hydration is the first step. Measures for monitoring and treatment of TLS and DIC, if suspected, should be in place. Once the patient stabilizes, further therapy in the form of induction chemotherapy and leukophoresis should be planned. Supportive management also includes cranial irradiation for leukostasis and neurological symptoms. Dexamethasone has been shown to prevent the addition of the WBCs to the endothelium and hyperleukocytosis associated with arsenic trioxide treatment in acute promyelocytic leukemia. This is the flowchart showing the management. The hyperleukocytosis more than 1 lakh per microliter. Initial workups includes the chest X-ray, NCCT brain, basic chemistry, screen and uric acid. First we give IV fluids without potassium or calcium, initiate urate lowering drugs. If it is asymptomatic, we start definite chemotherapy. If there is symptomatic leukostasis or WBC more than 2 lakh to 3 lakh per microliter, we go for leukophoresis. If there is signs of heart failure and severe anemia is present, that is hemoglobin less than 6, we consider exchange or partial exchange transfusion. If there is no signs of heart failure and severe anemia is not present, we transfuse to keep the target of hemoglobin 6 to 7 gram per deciliter. Now induction chemotherapy. Induction chemotherapy reduces the cell burden in 24 to 72 hours. If induction chemotherapy is not feasible, a low dose chemotherapy, hydroxyurea, cytarabine, in cases of AML can be considered. Lastly, the leukocytophoresis. The aim of the leukocytophoresis is to improve the tissue perfusion and to control or prevent the acute symptoms of leukostasis. In this procedure, WBCs or the blasts are removed from the patient's body and rest of the components are infused back. It is mostly performed in patients with AML and occasionally in ALL, CLL and CML. The improvement in symptoms gives an idea of adequacy of leukocytophoresis.
Hydration কারণ it itself will increase the viscosity. So they generally don't like giving too much blood. The target hemoglobins are pretty low. But লাগে যেখানে খুব মানে generally myeloid CML and CLL যেখানে খুব বেশি কাউন্ট থাকে আর সেলগুলো hemorrhagiologically they are very soluble, so they cause more destruction. Oncological emergencies এর মধ্যে most important আমরা neutropenia, sepsis, সেগুলো কভার করেছি, fungal infections কভার করেছি। এটা একটা part 2 আছে, part 2 কি আছে?
malignant complication syndrome আছে আর particular complication syndrome
this sort of situation usually causes hypokalemic